Hey everyone, and welcome to this explainer. If you're a medical student, a pediatrics resident, or really any healthcare professional gearing up for your boards or clinical rotations, you are in exactly the right place. Today, we're going to do a high-yield, high-energy review of one of the most heavily tested and, honestly, clinically devastating metabolic disorders out there, adrenoleukodystrophy, or ALD. We're going to break down the complex genetics, the pathophysiology, and the exact clinical pearls you absolutely need to lock into your memory. But before we get bogged down in the cellular details, I want you to picture this. You've got an 8-year-old boy. He's been doing perfectly well in school, hitting all his milestones. But suddenly, his grades start to slip. He develops behavioral problems that might look a whole lot like ADHD. But it doesn't stop there. Over the next few months, he progressively loses his vision, his hearing, and his ability to walk. And at the exact same time, he develops profound fatigue, weight loss, and a noticeable darkening of his skin due to adrenal failure. It's a tragic, terrifying clinical picture. How exactly does one single genetic mutation systematically destroy both the brain's white matter and the adrenal glands? Okay, let's crack this case by breaking the disease down step by step. Here's our game plan. First, the classic presentation. Then, genetics and pathophysiology, followed by clinical types and features, diagnosis and treatment, and finally, we'll wrap up with some high-yield exam pearls. Let's jump right into part 1, the classic presentation. We need to clearly identify exactly what disease we're looking at here. So the answer to our patient's mystery is adrenoleukodystrophy. ALD is a rare, X-linked inherited disorder. But here is the absolute most important distinction you need to make right out of the gate. Listen closely, because examiners love to use lysosomal storage disorders as distractors. ALD is a peroxisomal disease. It's characterized by the defective transport and dangerous accumulation of very long-chain fatty acids, or VLCFAs. And the inability to degrade these VLCFAs, well, that leads to progressive inflammatory demyelination in the nervous system, along with primary adrenal insufficiency. So we know the what. Now let's move to part 2, genetics and pathophysiology. Let's zoom in to the microscopic level to understand the root cause of this disorder. The disease actually results from a very specific mutation in the ABCD1 gene. Now, this gene encodes a protein called ALDP, which stands for adrenoleukodystrophy protein. Think of ALDP as a vital transporter located right in the peroxisomal membrane. Because the inheritance pattern is X-linked, this means that males, who obviously only have one X chromosome, typically develop the full, devastating clinical disease. Females, on the other hand, who carry one mutated gene, might remain completely asymptomatic in childhood, but they can develop milder neurological symptoms much later in life due to X chromosome inactivation. To really visualize what's going wrong, think about the contrast between a healthy system and a diseased one. In a normal, healthy cell, ALDP transports these bulky, very long-chain fatty acids directly into the peroxisome, where they undergo beta-oxidation. The result? A healthy, functioning cell and properly maintained myelin. But when you introduce that ABCD1 mutation, the ALDP transporter is totally defective. The VLCFAs are essentially locked out of the peroxisome. So what happens? They begin to accumulate dangerously, triggering a massive inflammatory cascade that leads directly to demyelination. It's basically a catastrophic domino effect. It starts with the ABCD1 mutation, which gives you the defective ALDP. As those VLCFAs accumulate, specifically inside oligodendrocytes in the brain, microglia, and adrenal cortical cells, they cause severe oxidative stress. This triggers relentless inflammation and myelin destruction. The end result of all this cellular chaos? Cerebral demyelination, spinal cord degeneration, and primary adrenal cortical atrophy. This is exactly why our 8-year-old boy lost his neurological function and suffered adrenal failure all at the same time. Now that we've got a grip on the microscopic destruction, let's shift gears to part 3, clinical types and features. Let's translate that cellular chaos into the macroscopic clinical phenotypes we actually see in patients. The tricky thing about ALD is that it doesn't just present one way. It actually has several clinical phenotypes. The most severe and classic form is childhood cerebral ALD, which typically strikes boys between 4 and 10 years of age, and it progresses brutally fast. But then you have adrenomyeloneuropathy, or AMN, which usually presents much later, in adulthood. That one is characterized by a slower, progressive stiffness of the legs and peripheral neuropathy, while cognitive function actually stays preserved initially.
You also have the Addison-only phenotype, where patients present strictly with primary adrenal insufficiency. Their neurological symptoms might not even show up for years. And finally, we have female heterozygotes, who might develop progressive gait disturbances and mild spasticity much later in adult life.
Think back to our patient at the very beginning. His symptoms are a direct reflection of exactly where those VLCFAs are accumulating. Neurologically, the demyelination leads to vision and hearing loss, ataxia, progressive dementia, and seizures. Endocrine-wise, the adrenal cortical atrophy causes that classic fatigue, weight loss, salt craving, hypoglycemia, and hyperpigmentation. We also see spinal cord involvement leading to a spastic gait and bladder dysfunction, and even testicular involvement causing hypogonadism and infertility in the adult forms. It really is a multi-system failure driven by just one metabolic roadblock. This brings us to part 4, diagnosis and treatment. When you see this clinical picture in front of you, how do you confirm your suspicions? And more importantly, what can you do to save your patient?
So the absolute crucial point you need to know is this. Your hallmark laboratory finding is going to be elevated plasma very long-chain fatty acids. Checking plasma VLCFs is the best initial screening test you can order for affected males. Specifically, you're looking for an abnormal increase in hexoxasonic acid, that's C26.0 for the biochemistry fans out there, as well as abnormal ratios of C24 and C26 to C22. If you see these elevated, ALD should immediately jump to the very top of your differential.
To round out your diagnostic arsenal, you're definitely going to confirm the diagnosis with genetic testing for that pathogenic ABCD1 mutation. You also absolutely must get a brain MRI. And listen up, because examiners love testing this specific detail. The imaging hallmark for childhood cerebral ALD is symmetric white matter abnormalities that typically start in the parietal occipital regions. You'll also want an endocrine evaluation, including morning cortisol and ACTH, to check their adrenal function. And thankfully, early diagnosis is becoming way more common nowadays, as a lot of countries now include ALD in newborn screening using dried blood spots.
When it comes to management, timing is literally everything. Hematopoietic stem cell transplantation, or HSCT, is the most effective therapy we have for early-stage childhood cerebral ALD. It can actually halt the inflammatory demyelination entirely if you perform it before significant disability sets in. Gene therapy is also emerging as an approved option in some regions, which is incredibly exciting. Naturally, these patients are going to require lifelong adrenal replacement with hydrocortisone and sometimes fludrocortisone. Now, you might have also heard of Lorenzo's oil. It's a mixture designed to lower plasma VLCFAs. However, it's really vital to know that it has not been shown to reverse established neurologic disease, and it is absolutely not a substitute for HSCT.
All right, let's bring it all home with part 5, high-yield exam pearls. It's time to consolidate everything we've talked about into the rapid-fire points you need for test day. You know, test writers love to trip you up by comparing different leukodystrophies. So let's look at how ALD stacks up against its common exam distractors. Focus on the organelle first. ALD is peroxisomal, while metachromatic leukodystrophy and Krabbe disease, those are lysosomal. ALD is X-linked, the others are autosomal recessive. ALD accumulates VLCFAs and presents with adrenal insufficiency and posterior white matter changes on MRI. Contrast that with MLD, which accumulates sulfatides and presents heavily with peripheral neuropathy, or Krabbe, which accumulates galactocerebroside and features those classic globoid cells. Keep these distinctions crystal clear in your mind's eye when you're reading a tricky clinical vignette. To make sure you never forget the core triad of this disease, just use the acronym itself, ALD. A stands for adrenal insufficiency. L stands for long-chain fatty acids accumulating, and D stands for demyelination. If you just remember those 3 pillars, you're going to be able to logic your way through almost any clinical question they throw at you. And for the genetics, lean on that mutated gene, ABCD1. A is for adrenal gland involvement. B is for brain white matter destruction. C reminds you of the most severe phenotype, childhood cerebral disease. And D points right back to the cellular root cause, a defective peroxisomal transporter. It truly is staggering how the failure of just one microscopic transport protein can completely crash entire systemic networks, from the brain's white matter all the way down to the adrenal cortex. It kind of leaves you wondering, how many other microscopic metabolic pathways are quietly waiting to be mapped, holding the keys to curing the incurable? Well, I hope this explainer made ALD crystal clear for you all. Keep studying hard, trust your learning process, and leave a comment letting me know which complex disorders should we break down next. Catch you in the next one.